All right, so I'm inviting on stage our esteemed panelist for this session, Dr. Corinne Idnani, MD, Medical Physician, Dr. Idnani's Medical Clinic. Dr. Corinne, can we have you here on the dais, please? Please come in. Dr. Dushchand Barfiwala, Medical Director and Partner, Dr. Ranbir Singh Clinics. Captain Arun Mehta, Managing Director, India OSM Thome. Captain Deepak Korea, COO, Elegant Marine Services Private Limited. Captain Vikram Singh Manhans, Deputy Nautical Advisor, Senior DDG Tech, Mercantile Marine Department, and the moderator for the session, Captain Deepak Gupta, Director, Tanker and Gas, Anglo-Eastern Ship Management Limited. I request everyone to please take your seats. The panelists are already here.
Ma'am, I think we're good to go. We can start. Or should we wait for everybody to come join in? So, good afternoon once again. Esteemed panelists, guests, doctors. We are on to the second session of our deliberations on the new DG guidelines. And before we begin our deliberations, I would like to, from the industry end, congratulate DG on taking this initiative. It's not every day administration actually comes around on a consultative status to the stakeholders of the new regulations, and this is a very welcome move. So thank you for that, sir. I also want to kind of bring this to the fore that the detail to which Directorate has gone into areas and subjects like what's the waiting area available to the seafarers, the convenience, the amount of running around that they're doing. And I really hope these new regulations would form that benchmark, the standard, what we offer to our seafarers before they go on board the ship. So that's a very welcome move. And even before we begin these deliberations, one of the recommendations I think which we would probably make to the administration is regarding the medical practitioner module that you have developed. And you saw in the last discussions that we had about keeping the doctors updated about what's exactly happening in the medical scenario in terms of the maritime sector and the need for it. And what we kind of gathered in our group was that this is a wonderful platform that you have developed where you're applying for your licenses and also for the refresher courses. And if you could use this platform for keeping the medical fraternity updated on the maritime side, and that would probably solve the problem on the area and the front where people are getting a lack of information, especially when we have representation from across India and not just metro cities. A good doctor mentioned to me in our office that medical examination is 60% observation and 40% diagnostics. It's a very welcome move that now this refresher course is being updated. And if you look at the annex, it's quite expansive. And I'm sure that is going to make certain problems go away from us. For an example, just to quote one case, we had a seafarer on board without one eyeball. And I'm sure those are the things that are going to get negated. So to start the discussions and with an objective and aim that we are here to get together and probably combine together to make some recommendations to the Directorate on what has been guided and what can be amended. So our area and scope of discussions today would be the proposed quality assurance standards for the PEMI centers, specifically the NABL standards, and of course now extended to the NABH and ISO 15189. Facility standards in respect to the PEMI centers, tests mandated by the DG, which is over and above what is being mandated by the ILO and WHO, and the formation of the National Database Center, which is being talked about, where the reports will be uploaded, and how best that can be used by the stakeholders in the industry. To start the deliberations, I first have my questions for the stakeholders of the medically fit seafarers. So Captain Deepak Korea and Captain Arun Mehta, followed by questions to Dr. Dushant and Dr. Idnani, and then finally, probably collectively, we would have some positive recommendations to you, Captain Manas, and probably have some questions for you as well. So, Deepak, coming to you as the first question as part of this deliberation is, as a final user of medically fit seafarers, what is your observation on the medical sign-off that you are noticing? And where do you see the gaps? And do you think the new rules that have been initiated by the DG, are they covering those gaps, or is there something still wanted, or you are left wanting to see something more being added or something being deleted out of that? To just kind of profess that act, I bring the data from my own company because we represent a pretty large number of seafarers, and we have about 0.3 to 0.4% of seafarers, about from 25,000 joiners, which are signed off within 60 days of joining. And that leaves us wanting, because that 60 is like, that golden period where we expect nothing would go wrong, right? So within 2 months of joining, we are 0.3 to 0.4%. So I would like to see, as a large employer, what's your reading on an industry basis of this, and what would you see?
Yeah, first of all, I think the proposed draft that DG has proposed is definitely welcome. I mean, we can deliberate, make some changes to it. We could discuss on the various modalities that it brings in, but that said, it is the need of the hour. We couldn't be living with the old medical rules for very long. That said, I think your stats very much sort of echo or align with what my organization also suffers. And I will admit and I will say that there is a gap. There is definitely a need for improvement in terms of the quality of tests that are done. And when I say it's not test, examination I think is the right word, because test would mean only biochemistry. So examination and the quality of the clinics per se. So I think both areas we need to focus on, and we've suffered like many organizations. Captain Anshul also gave his examples, and I'm sure you have your own. So it definitely needs a look-see, in my opinion.
I'll kind of extend this question a little bit more. You do see a gap, you do see a scope for improvement, but when we are going back to the stakeholders, when we are talking to the owners, the people who are coming and investing in India, they're talking about facts. So would you be able to put a number, like what kind of percentage are you seeing which you can directly attribute to the lack of proper quality standards currently in market for the PMS centers, and this DG's initiative to overcome that gap? So what kind of gap are we kind of closing up?
Okay, if I look at the PNI sign-offs, and we just did an analysis, our fleet care team led by Captain Mahadik, we just did a complete analysis of all the PME sign-offs we had in 2024. And if I discount those illnesses which are due to, say, contact dermatitis or a malaria which sets in 5 months down into the contract, if I discount all that, then 63% is what we can directly attribute to the PME. Now, it will be unfair to say 63% because there are panic sign-offs. Now, if a boy has a boil, then either he or she or the master will sign him off immediately, which never used to happen earlier. So I think let's take 50% of that to be very, very fair to the clinics. So anything 32% is what I feel is directly attribute to the clinic and the quality of medical examination.
I think that's a number we also ponder upon, that a very large stakeholder currently in the market attributes to close to about 40 to 50% directly attributed to what DG is trying to cover up by making quality standards mandatory for everybody to follow. And what kind of mandating is to be done, we'll be debating further. Captain Arun Mehta, can I? Going forward with what Deepak was mentioning, he's attributing 30 to 50% of the failures that are coming around here. What we're seeing in the new regulations is, or the new draft regulations, is that there are a lot of medical examinations which are over and above what has been mandated by ILO and WHO. And when we speak about that, we'll take into account that not the companies which are just members of FOSMA and INSA and MASA, but everyone who are currently being serviced by the doctors. So all the other 500 combined. What do you think is the legal challenge to this medical standard being professed or being promulgated or being mandated? If I take currently our standards, you look at about expense of about 40 to 50 US dollars for a particular PEMI to be done, one PEMI, and an average costing. Obviously, that's going to go up. So, do you feel that the industry is going to push back, or do you feel that they would realize, they understand the scope of where DG is coming from, where the directorate is trying to point at, what is it trying to prevent, and do these additional tests, because the number of tests that have been mandated are quite extensive. What is also extensive is the guidelines on which you can make a seafarer unfit. And those guidelines have been expanded quite a bit. There were mentions of dental fitness and abdominal fitness in the earlier circulars as well, but this time it's absolutely clear. So we are going to face a large number of medical failures, and we are going to face certain problems going forward, but of course, at the end of the day, we'll have healthy seafarers go onto the ship. So what do you anticipate the pushback from the industry? What do you think overall is the representation that is towards these guidelines that are issued?
I think from a cost perspective, if you're looking at it, I think the good companies and the good owners are going to absorb the cost to a large extent. If I look at it the way we are already doing it, we are already doing much more than what the current standards actually require. There is a much higher level of medical fitness which we are attributing to a seafarer, considering that we want to keep the trends which we see are rising. We want to stem those trends, rising trends. As of now, for example, I think this would hold true for most of the companies. We have got about 7 different levels of medical fitness tests which need to be done. The second thing, for example, what we do is, we don't go with what is the medical certificate's validity requirement is. We spend the money, we invest in it, and we ensure that every time a person is going back on board, it is that they take a medical examination. And that means that we are already sort of investing into this part of it. Now, the important point which will come up with these standards now is it will put an onus back on the seafarer to remain medically fit. Because one of the other things which we are doing is when a seafarer comes, we ask for the last medical certificate, fitness certificate from the seafarer. If he doesn't have that medical fitness certificate, then we make sure that he has to do a more extensive examination. So from a cost perspective, I don't see that for quality companies, this will be a major pushback as such. Because we understand that we are partners to stakeholders and ship owners. And we understand that when we look at it in an overall perspective, the cost savings we can do for a ship owner in terms of a P&I case which is rising will offset this whole cost,
Yeah, I'll add to that. So if DGS mandates that the PME validity is 2 years, and we accept that as 2 years, and we can do a more sort of an easier test the first year, So that's one way you can offset. I do believe that it's not so much on the DG, but if organizations like us can demonstrate that with these packages we've been able to bring down the sign-offs, then I think it's a game changer. I think we will have more and more owners agreeing to it. So the onus is also on us. Also, there is something which we should be very aware of also. The outliers, the things which do not really cover and is not been discussed here is that if I as a company decides to go for the highest PME standards and I have only 2 clinics who do it, and I have with my numbers so many thousand people walking into those clinics, their USG machines can't match up. I don't know if the biochemistry machine can match up. So, and the TMT which needs supervision. So one has to be mindful. So as organizations, when we decide to accept a certain standard, we should look at whether the clinics have them, they're equipped to handle the numbers, or do you have to look at multiple clinics to fulfill your requirements?
Yeah, actually, that was one of the questions I was coming to you, Dr. Idnani. I was about the small, medium, and large scale operation, and how is that going to be affected with this regulations in place? But I'll just come to you in a minute. I have one more question for you, Karen Mehta. Two sides of the story, 30% attributed to purely the quality standard or the kind of quality report that was received. Verse says, you claiming, or all of us combined together saying that we are good companies, we are taking adequate precautions, we have 13 or 15 different levels of examination levels for different seafarers, making sure our owners do not have a problem. Now, one of the stakeholders of this medical fitness or having a medically fit seafarer on board is also the P&I Club, which is not represented here. But of course, that does take its stake quite seriously. So if you look at the centers that are being operated across India, there is this P&I approval in place. So my contentious question, and probably not in the wrong way, but in the right way, is do you feel the need for these regulations to come in force when there are already self-regulating forces in place, such as P&I clubs, etc., who are doing their best to ensure that what they have on stake is not affected?
Okay, I think this is a loaded question. So, let me.
I didn't want to put you on the spot,
no,
but
that's fair enough. I'll try and measure my response on this. But I think okay. So let's look at it from a perspective of saying what is the P&I trying to do. Okay, so there is a stakeholder in the market, which is the P&I, which is an important part. But their contention is they're representing the insurers, and their contention is to remove and reduce the insurance costs primarily. Okay, when you look at what the administration is trying to do, it's probably a slightly different onus. It's looking at what is the Indian seafarer and the community and how do we build up that standards. I think there is a rising trend on Indian seafarers, which we see when we look at cross nationality, where we see that the medical sign-offs and the P&I cases are on the rise. That attributes to general health. We've been having a discussion. I think one of the things which will, like I said in the beginning, the seafarer, when he comes to you, and we just had a side note on this, has to be medically fit. Just like he or she has to have a certificate of competency. If they're not, then they're not fit to go on board. So the onus of this will translate back, little bit of ownership back to the seafarer, that they will have to make sure that they are conscious of the fact that they live up to the higher standard of medical fitness. So in that sense, if I look at that perspective, then it needs to align. It cannot be tangential to what the P&I standards require, or we can't live outside the global, how should I say, ecosystem of this. So it does need to align with what the P&I requirements are. And if it has, the challenge which I see is, probably is that different P&Is have different standards, and that limits to the flags and to the vessels. We are coming up with a common standard, and we say, what is preventing a seafarer to say that, I am okay with this standard, why are you wanting me to do a higher standard? This is a pushback we get when we ask for additional tests, and vice versa. So there is a little bit of a aspect of wherewith, but I think that, like we said, market forces, this will devolve over a period of time. I think the intent has to be that there are multiple stakeholders, there are ship managers, there are recruitment replacement companies, there are ship owners, there is P&I clubs. Each has a different aspect to which they are trying to address. I think there has to be a buy-in from the seafarer. If we do not have that buy-in from the seafarer, we can keep sitting in conclaves and we can keep coming up with standards, but nothing will materially change on the ground. So I think that if this standard can address, and if this can be done from the DG's perspective, because they have that administrative control, then yes, I think it will be good for everyone.
I completely agree with you. And so as you as administrator, I think the news from the stakeholders is we are all thumbs up for it, actually, in terms of expanding the criteria, because we have looked at the present criteria and seen it not work for us. But there is a little bit of let's say, a gray area about when we compare what India is trying to do with the offshore industry or the shores outside India. And what we are finding is, if I was to just step out and go to any other, so for example, we looked at Philippines yesterday, and after deliberations, and tried to see what are they doing, because they are another manpower supply nation. and found some standards missing there as well. So we're going one step ahead of them. But if I just go a little bit more to east, and if I was to go to Europe, some of the tests mandated by DG would not be done unless you're sick. So they would stick around and do only what's required by ILO. And if you look at the differences in percentages of what we are experiencing in terms of sign-off and the problems areas, there is not much. At least I can speak for what we are putting on board. So one of the areas that probably can be deliberated upon. But thank you very much. That's from the stakeholders, but now for the doctors. So, Dr. Dushyant, I'll come to you first.
Me first.
Sorry? Okay, ladies first, absolutely. That's my fault, ma'am. You put me in a spot now. Sorry. So I'll come to the hot topic then now, the NABL standards, or the NABH standards, or the ISO 15189.
Let's see what the questions are.
Ma'am, what challenges do you see in complying with these standards? And when I want you to answer that question, I probably want you to represent the entire room here. In terms of what do you see as a PEMI clinic, and what advantages do you see of applying these standards? What can you give us back in terms of returns on that? For example, Deepak mentioned that if we are already increasing to these standards and we have full confidence on the reports that are going to come out from these standards, and also give convenience to our seafarers, would we be in a position to recommend to our stakeholders that we are going to increase our PEMI levels to 2 years? Would we be able to bridge that gap? Would we be able to reduce that intermediate, every contract, medical to be done, etc., etc.? So what is your reading on the positives of NABL? And we'll go to the negatives, of course, we will not leave without that.
So basically, right now, I don't think there's any assurance that putting in the NABL will bring down your repats or the crew members who come back. I don't think there's any guarantee on that, because the NABL is a totally different. It's a totally different package, and to enroll into NABL, I think we'll go further with Dr. Dushyant. I don't think it'll make a difference. But may I go back to something you said earlier?
Sure, ma'am.
When you assessed the comebacks from your PIMIs, you noticed that there were about 35% of them which were only due to PIMIs, the PIMI factor. I think if all of you could get together and analyze what were the cases that came back, we have some kind of study on it, and that would definitely help in increasing or, adding value to the new DG tests and the new DG standards that are going to come in. Because that may add some value there, rather than say we don't know why they're coming back or try to justify something in any other way.
I'm sure, Dr. Nadi, that itself is a very wonderful suggestion, and I go back to the platform which DG is making, and possibly there is a scope for us to, kind of keep it dynamic and keep it focused on why we are having returnees and on which area are we having problems, let it be cardio or diabetes or mucus skeleton or whatever the case may be, but probably that gives us focus areas to work on for the coming 3, 4, 5 years. And yeah, that is one of the things probably that can be taken off as a suggestion from this discussion. Doctor?
See, my contention is very simple. If you are going to say that a doctor is responsible, a PME clinic is responsible for not doing a test properly, or something to that effect thereof, the problem is that you are not sharing information on the causes of this. There are many diseases where you cannot give a diagnosis on the time you see the person. That disease is going to evolve. So if it is happening in that evolution period, you are going to face problems. The problem is that nobody wants to look at it that way. They are saying, you did the medicals, you are responsible. Prime example, somebody comes to you, you do his medicals, he has no fever. He goes on the ship, 8 days later he gets fever, He's in that incubation period. How are you going to diagnose him? And then putting the onus on the clinic and saying that give us an explanation. Sometimes, for a doctor it is a little frustrating. And you need to consider these things when you are putting the buck on the doctor. Now, just 2 minutes more. You asked me what are the problems of doing NABL. As a clinic, the problems that I face are 3, 4, but they are big walls to climb over. The first problem is that I need 6 months data before I apply for NABL. It doesn't happen on the spot. And the DG shipping needs to understand this. So therefore, if I want to start a new clinic, I can't. Because unless I have patients, how do I get the data? And if I don't get the data, how do I apply? So it becomes a circle. You're going round in a circle. The second problem is your clinic has to be an LLP or it has to be an ownership company. You cannot have a simple clinic as an ownership applying for NABL. The third problem is that you need to employ one person dedicated only to doing paperwork. You have to maintain for each person about 62 files. I may be off by 5 or 10 on this number, but you need to have a person doing only this. And the last point is that NABL arm twist you. They make the conditions so stringent that sometimes you wonder that, look, I am not treating someone. I am examining him to join a ship. He is not sick. Seafarers coming to me generally are not sick. I am playing Sherlock Holmes. I am trying to find out what is wrong with you. Whether you disclose it or you don't disclose it, I am still probing you. And that probing goes on throughout the condition. Majority problems happen because seafarers don't disclose. And there are multiple reasons for it. We've discussed this earlier. Now, what does NABL bring to a clinic? We've spoken about the problems. Let's talk about the advantages. What does NABL bring on board? It brings increased competency. That means it makes your staff more competent doing those tests. Then, questionable thing, it gives you market reach. Market reach is a notional concept. It may work, it may not work. And finally, it gives you full operational control. It tells you where you're going wrong, how you're going wrong, and what you need to do to correct it. Finally, the biggest advantage of NABL is you get DG approval. That is very important. Is there anything else I can answer?
Dr. Shah, I want you to hold on that thought for a minute.
Yeah.
Okay, and I'll just take the last
Yeah.
bit that you took up. We'll leave the DG approval for a side, but I want your opinion on a very pertinent subject. You mentioned that NABL gives you guidance, and I've been through NABL, so it gives you a lot of quality standards on how the test should be conducted, etc. Now, my question to you is, and probably to everyone here is, do you find value in having parallel standards mandated by DG, which could better control the situation instead of just having an NABL standard? For example, maybe we could mandate guidelines that your machines have to be calibrated once every 6 months or 1 year, or you should have certain reproducibility of your results, or you should have certain authentication of the same result that you produce for a person, and would that probably give you the same result as what NABL would give you? And do you find value in doing that as a recommendation to the administration?
So what you need to understand is, what does NABL do? NABL gives you 6 steps. The first step is you have to have your SOPs. The second is internal quality. Internal quality entails that you do controls every day. The third step is external quality, where you're sending your samples out, or you're getting samples from outside and comparing it with your reports, and you are getting, standard deviation, so on and so forth. The fourth is calibration of your equipment and its machine maintenance. The fifth is training and competency. And the last step is audit.
Yeah.
So my contention is that if you do the first, all the steps before the audit, as is mandated by NABL, and the DG Shipping appoints an auditor of their choice, preferably an NABL auditor, to come and make sure that you've done these things, then two things happen. One is the DG Shipping has direct control that this is actually being done. And the second thing is the doctor is spared the trauma of going through NABL. You achieve the same purpose without doing this. That is why I am very reluctant to say this is NABL. I would call it a quality assurance service. That is a better terminology to use.
No, your point is well taken, Doctor. And yeah, that's something that's...
The last thing, sir, the last thing is the cost. See, when you want this sort of strictness when you're doing medicals, you are going to incur a big cost. Now that cost the PME clinic cannot pay. It has to be borne by the company. You are talking of almost doubling your cost. The second part is because you are doing things in such a strict manner, your time constraints will come in. So all this business about flying tonight needs to go. All of us as doctors face this, and that is going to stop. You can't blame the doctors for this. The final point I want to make is that you may do NABL, you may do everything. Where is the guarantee that if you do NABL, the rotten apples in the group will not continue to do what they are doing?
Right. Dr. Dishan, thank you. It's quite clearly what you brought your point forward, but since we are a little tight on time, I would like to go to Captain Manas with what we have deliberated here and what the recommendations are. And sir, it's quite clear. I mean, from the stakeholders end, we welcome the initiative that has been taken by DG Shipping on and reforming these guidelines completely, adding a whole lot of new structure into this so that it becomes very clear for everyone. The most important one on sharing of databases, right now it's only dates, but I'm sure we'll all find a lot of value in having this data more and more available to the industry so that we are able to employ the right people. Nobody finds any happiness in getting a seafarer back home in any other state than happy. So it's a very good move, sir. But as you can see from the stakeholders, they do find a gap in the quality standards. They are attributing 30-40% of their people coming back because of the lack of the quality standards. If you look at from the doctor's end, they're finding issues in terms of going to a certain accreditation standards, and they're not finding any value in that, and what kind of value addition can take place. So from a legal perspective, from an administrative perspective, how do you take this feedback, and what areas do you think we can cover the gap between the service provider and the user?
Thank you. So firstly about NABL, I appreciate all the discussions, not just now, but even during the entire session since the morning. And we have actually noted down all the challenges being brought out, especially by the doctors as far as NABL is concerned. So I would just like to speak a little bit about NABL. So basically the intent of DG Shipping to bring in NABL is to bring uniformity and quality assurance and quality control in terms of your laboratory analysis. Because this is very important, because it's based upon this, the doctor is making a decision. And I know everything cannot be, you cannot find out everything by those results, but at least they give you a fair idea about a person, if it is done properly and correctly. So now as far as NABL is concerned, we all need to understand it is an accrediting body, right? And when we talk about ISO 15189, if I'm not wrong, it is a standard. Okay, standard, and this is an accrediting body.
Correct.
So in India, this NABL, it is a government body basically, a government organization, government accreditation body, which is under DP, IIT and Ministry of Commerce and Industries. So somebody was pointing out in the morning that why can't we have from XYZ accrediting body? Say you go to accrediting, there are numerous accrediting bodies
Yes, there are,
across
sir.
the globe.
Yes.
So now, if you go, say, accrediting body which is recognized in Singapore, right? When you come here, as far as the government is concerned, why, when accrediting body is recognized or approved by the government, there are some norms or conformance which they need to show. You know, while they are like a third party bodies which are going and doing the inspections or audits, and then they are certifying them. So now the government would not have any control over the accrediting body which is not falling under its jurisdiction.
Yes.
Yeah, you see, so then the whole idea of having a uniform standard is kind of lost, or it cannot be enforced, if I say correctly. So that is the reason why DG Shipping is now looking at NABL, because I understand this is one, I don't know if it is the only one, but it is one of the approved accrediting bodies in India. And standard, we are talking about 189 or whatever, is one of the standards which NABL would test the medical laboratories, right? There could be many other standards, but so important is from where you are getting the accreditation. And then somebody was talking about ISO. So we need to understand there's a difference between accreditation and certification. When you talk about, say, ISO now 9000, it is just a certification. It is not accreditation.
Yes.
So that is the reason, and why we have come here. I'm not going to repeat myself because we have discussed this since morning in quite depth, that there are gaps and the stakeholders themselves have brought it out. And so this is a step which the administrators think is appropriate to move ahead, and it will be done in a gradual and incremental steps, if I may say so, and it cannot be thrust upon. And that is the reason why we are having this conference, and where we are discussing how to take it forward in a manner where it's not a disruptive thing, but it adds value. And yeah, of course, one more thing I heard was that it doesn't guarantee that a person would stay healthy. That is correct. There is no guarantee to it. But what it does, or what it would guarantee, is some kind of quality control and bare minimum standard. So I think that will weed out a lot of issues what we are facing. So that is about NABL. So I think anything else about NABL?
No, sir. Actually, Directorate has already opened its clause for NABL, NABH, and the ISO standard itself. So that's quite a welcome move for the PEMI centers being represented here. Of course, at the end of this deliberation and the results of that, we might, kind of write back, which is the primary purpose of having these deliberations, about what we think could be alternate solutions on how this can be standardized and what value we can get out of it. So thank you very much for your comments, and Deepak, thank you very much, Doctor.
Thank you.
Yeah. Do you have any comments which I've missed out, or anything that you need to add?
She wants to
Yeah, Dr. Idnani?
I just want to say one thing, that when we started this whole panel discussion, we spoke about, when you have accreditation as opposed to certification. So an ISO body will accept you, will accredit you, will standardize you, and any laboratory which is within a regulatory organization's control, like us, like PME doctors, would do well by just having standards, by keeping regular controls, by signing up with bodies like ECWAS and doing biorad testing. These are internal controls on your own mechanism. Then sending your work outside is also a quality control of your own
Calibration
work,
of your
a
equipments.
calibration of your, a regular calibration of your equipments, and keeping all this data also shows very good, good working habits and good control and good clinical judgments. Thank you for taking time.
Thank you, Doctor. If we are to sum up this celebration before we open the floor for some questions, ma'am, we have time for questions, right? Do we have time for questions? Yes. Thank you. So, from the stakeholders' end, I think we welcome this move. This is a very welcome move. One of the most positives that we get is that we have doctors more educated on what exactly is happening on board. Just coming short of you actually going on board and experiencing what is happening there, at least there's an introduction to what's happening. And what are you certifying somebody for, right up to the extremes of India. So that's a very welcome move. Refresher courses, as we recommended, could be used as a very dynamic platform on continuous education basis for the doctors to keep them updated of what are the pertinent issues. Another recommendation that came out of the stakeholders from Deepak and Captain Arun was that, probably open this floor for us as well, so that we can put in our own feedback about what are we experiencing as the end user of the medically fit seafarers, and how we can, give back what are we experiencing to the administration to take that into account when you reformalize the policy or revise it. And of course, from the doctor's end, the pertinent problems of obtaining and the accreditation under NABL, of course, being open for NABH and ISO. So I don't know how Directorate would be looking at various centers and their quality, and how would a center be judged basis whether it's ISO certified or NABH or NABL, and who would probably be given a higher rating, and whom would somebody want to go to. We also see advantages of this accreditation in terms of not something that's materialized right now, but may be into fruition later, where we see that such stringent procedures might allow us to increase the PEMI intervals and not go into the regular basis of having a single contract, single medical kind of a situation. That would probably give us a faster turnaround time. A lot of people mentioned there, aaj hi raat ko jana hai, kal hi visa apply kiya hai. So those kind of situations might come down to once every 2 years, and that would be possibly a positive outcome, but we don't see that validated right now with any data in place. So that is something to see what these guidelines finally come out as in its fruition period. And we would now open the floor for some questions, and please, lots of them.
This is my chance to ask questions because I'm on the other side of the dais. Sir, this question is addressed to Captain Manhas and the administration. Recently, there was a big hullabaloo about a circular which said you cannot have more than 2 doctors in any facility. Now, picking up the cue from what Deepak said about the volume, sheer volume of people that go through the medical examinations, some of us have our preferred doctors, clinics 2, 3, 4, whatever. But to put things in perspective, one clinic may have 100, 150 people going through a medical. It's not physically possible for 2 people to do those medicals. So as long as checks and balances can be maintained, I don't see any reason why we should have a limit on the maximum number of doctors. Yes, he should not be in 3 clinics at the same time. Those balances are mandatory. But why would we want to limit the number of doctors in a facility if he's got the bandwidth to pick up that business? Thank you, sir.
Thank you, sir. Thank you for your question. And since these medical rules are coming up now, and this discussion is primarily to take your feedback on these issues, and we will take this thing with us, and we will make sure that rules address this, and once the rules are there, this will be superseding all the existing executive orders. Thank you for your question, sir. We will take this feedback.
Good afternoon, everyone. Sir, very enlightening. First, I want to make a comment that I welcome the move from DGS to amend these rules. That's very, very heartening.
Yes, this was clear right from the beginning.
We have to change with the time as per the current scenario. And the other good point which DG sir and Captain Azad sir, Captain Mukesh also said, that they are going to do the consultative and the feedback mechanism. I am coming back to this only, one question about this P&I accreditation you asked to Captain Arun Mehta
Yes.
on that. So I would say back again, it should be something which has to be really thought about. It is not easy for doctors to go and get accreditation for P&I club. It is not so easy. Especially if you are from the intercity, Captain Tandon just said, हमारे यहाँ पे small cities, we have got lot of DG approved doctors. But to today's scenario, seafarer would like to go to the nearest place for his medical. And all the good owners, good companies want to give that facilities to him. We don't want them to travel hundreds of kilometers far off. So keep in mind, whenever this thing is there should be a consultative and not to make it so detrimental for the existing doctors. Actually, as an employer, I'm not talking as the employer, I'm talking on behalf of the doctors, but for the betterment of a seafarer. So we would like that thing is there, kept contained.
Yes, sir. Thank you, sir. And that is always the idea at the directorate. We do consider, and that is why some leeways are also given to the doctors which are located in tier 3 cities. I am not even talking about tier 2, because tier 2 there are a lot of doctors and a lot of seafarers now. They don't have to travel to say metros or this, but slowly and slowly as the industry grows, this will come up in tier 3, and we will provide all the support from our end to have them implanted there and survive and sustain there. Thank you.
Respected doctors and the stakeholders, the data that was presented, 30 to 35%, is coming from the companies who are already doing enhanced PMEs. So the list of tests that DG is proposing may not really help them because they are already doing that.
Yes.
Now DG is coming up with NABL or NABH or ISO 15189. Now when we say NABL and ISO 15189, they both are same. They are not two different things.
Correct.
It is a standard, and that is the body which accredits that. So these are not two different things. Now, the intent is perfect. We want to improve the standard. How do we do that? Is NABL the highest level which is needed, or we have something here also? So what do we have right now? We have something called as Dr. Barfiwala sir was telling, ECAS, External Quality Assurance System, and it is not just a verbal thing. The clinics do get a certificate of ECAS compliance from CMC Vellore, which is the highest body of ECAS certifications in India. Even NABL gives certification basis that ECAS. So, because NABL does arm twisting, and we are, compelled to just go to NABL, my suggestion is, let's bring in some standards wherein we ask the clinics to produce ECAS certificate. And for quality management system, we definitely have the various ISO standards. So by doing ECAS plus ISO certification like 9001, we achieve both, and we still not increase the cost, which will serve the industry, the doctor, and the every stakeholders. So we must look into this rather than, straight away saying that NABL is the answer or NABH is the answer. That's probably not the answer. That's why you are seeing so much of opposition from a lot of doctors, but maybe we are not very good at, putting our point across. But this is in brief what is the challenge, that the intent of getting the quality will be achieved by having ECAS certificate. And remember this, NABL or the standards that we are looking into right now will only improve the standard of laboratory results. PEMI is a very holistic approach kind of thing. If you look at the data and see the reasons of medical sign-offs, are they connected to the lab values, or is it hernia being missed, piles being missed, kidney stones not being reported, dental issues?
Yeah.
So is it the lab issue that you want to address, or you want to address the PEMI? So we have to look at it in this perspective, and then maybe it will answer your question that we may reduce the frequency of PEMI to once in 2 years. And still, even by doing that, I mean, we have spoken to a lot of cardiologists, we speak to them very regularly. The only way of, reducing cardiac complication is by doing an angiography. No other test. I underline it 2 times. Not 2D echo, not PMT, not ECG, no, nothing will ever predict whether a person will suffer a cardiac block. This is, underlined 2 times.
Thank you. I just would like to add a small little bit. I think one of the clarifications on behalf of Captain Korea on reductions from 35% downward trend was also to do with the fact about DG getting into an area of data which is absent currently. Although some reports have started to get uploaded, but data being available, which gives you a little bit of a medical history in terms of what we are looking at and what patient are we dealing with, which allows us to, kind of be careful when you're doing things. That is one of the helpful points. The second very helpful point is the direct relationship between the PEMI doctor and the seafarer himself, eliminating from the company in between, because if you look at the entire scenario, the biggest loser of an unfit seafarer is the seafarer himself. Others are just the collaterals.
Yeah, Deepak, I'll also go on to add that since I brought up the percentage, and I think I'll get usually unpopular, among the doctors, and I can't afford. I have a long career here. But that said, what I tried to highlight was the problem at hand. That figure is our problem. Right. Not your problem. All I'm saying is that is there for us to stare. My owners are after me and I don't have answers. And what you said is right. It is the examination and not just the lab. And not only there, one step ahead, we have to make SOPs for comorbidities, which we need to give guidance to the as employers or as DG to how these needs to be addressed, so that we don't write off a person from gainful employment. We need to have SOPs for existing medication and existing ailment you have. So some companies are already doing that. I think if we standardize that, we can make it better. But whatever we do has to be collective. So it can't be just these rules.
Right, sir. So, various guidelines and standards that we come across. If you say fitness is whether the person fits into this. These are the criteria. So, if this is ILO, P&I club is this. Whether this person will fit into this. So, the guidelines, if we jump to P&I club, we will lose on a lot of seafarers. Whereas, if we keep this, we will have lot of sign-offs. Because this has a bigger loose criteria. So ILO is pro-labor, it wants to give more and more employment. Whereas P&I Club is pro-company, wants to reduce the cost. It wants to work against the ILOs to actually, make stringent laws. And we have to somewhere sit in between, so that we strike a balance between achieving the both. And maybe it will always be a race to achieve what we want to, but at least we are doing one step in the right direction.
Thank you, Doctor. I think we have time for just one last question.
Yeah, just maybe one last and we'll have to.
Good afternoon. I want to address the question of 2 doctors in a clinic. Perhaps the administration and administrators are looking only at PEMI. But in our clinics, when we do a PEMI, there are certain seafarers who are unfit, temporarily unfit. We need to counsel them, treat them, review them. It takes time. We have seafarers coming back for treatment post-repatriation. We have to take a detailed history, refer to doctors, speak to doctors, convey the pertinent information, visit them in hospitals, generate a report for the owners, the P&I club. It takes time. Somebody suggested secretaries could generate a report. Yes, of course, they do in the US, Philippines. We don't have medical secretaries in India. They're not trained. And lastly, there are unannounced drug testing on board. If I have to go to JNPT, I leave my clinic. Other doctors is on bereavement leave, annual leave, sick leave. My clinic is absolutely unmanned. So perhaps the administrator and the administration could take into consideration all these aspects and waive this restriction of 2 doctors per clinic. Let the market forces, let the dynamics of a clinic determine how many doctors. If I have the appetite for a larger business and I want to employ more doctors, so be it. If I'm happy with what I'm doing, I'm alone, let it be. There should be no restriction. That's what I wish to say. Thank you.
Thank you, sir.
Thank you.
Point taken, sir.
So thank
And
you,
we'll take it
everyone.
up.
Because of
think,
paucity of time, we'll just have to move ahead. Maybe the
Manas-
last reflection here.
Nothing, I was just thanking him for his comments. I think we've had this twice about the two doctors, and administration has taken note, and we will discuss it at the committee and see the best way forward, taking into, keeping the interest of everyone as paramount. Thank you.
And thank you all, thank you the panelists and guests and administration. This was a very constructive debate on the regulations, and I hope we would have put a point across. Thank you very much.
Just before you wind up this session, see, as administration, we need a clarity, no? Because somebody is saying NABL is good, somebody is saying NABL is, is expensive, some other doctors are saying it is very easy. So finally, we need to come to some conclusion by end of the day. So please draft a line. Your clinic should be approved by what standards? See, we are here to prescribe the standards which are feasible, which are acceptable to the industry, okay, and it should be reliable. See, as Captain Manas said, standards everybody knows, but what is the accreditation body we want? Either NABL, you said some other standard. As a government, we can't prescribe some private thing. So we should, either it should be open-ended. So let us give a text. I think Captain Nitin will be here. So we will try to formulate what exactly is workable. Okay. Now another thing I just wanted to highlight is, even if when we are going for, you said about it is only laboratory test. What about X-rays and 2D echo? Whether those things also has to be NABL approved, because that is also done by, or is it where?
Not in the scope, sir.
So that is, so laboratory. So there means various tests. So what happened? Like now we are going to mandate now ECG, 2D. So many things are being being made mandatory. So first of all, we need some clarity. We are not a medical expert, so you have to tell us as a collectively. So what is best? See, what sir said about 30% failure is the company which is already having a much more higher medical test. But what we are facing about the remaining rest of the companies where there is absolutely no standards, So we need to have as we are not obsessed with any NABL or NABH. You please tell us exactly what will ensure quality. That is the only thing I wanted to tell you. And I just wanted to clarify the last session Captain Basim sir has raised about the circular which we have released, about the age, you can say that conditions for a seafarer. There are 3 points just to give clarity to all. The first point is for Indian ships not having lifeboats. Okay, sir, that is the first category. Indian ships not having lifeboats, seafarers should not, seafarer above 65 should not be sent on board. But if you want to send them on board that ships, then they must take a permission from the Mercantile Marine Department. What Mercantile Marine Department is doing, they are sending to the doctor to conduct a physical fitness test, other than all this laboratory test. So I hope this is clear. As far as Indian ships without lifeboats, 65 is the cut-off age. Beyond 65, we are not stopping. Application shall be made to the MMD. MMD will call them and see physically the seafarer is okay, and then send him for a physical test and verify the lab reports and everything. Basically, it is some kind of due diligence by the administration. This is the first condition in that circular. Second condition is any ships, 70 is the cutoff. 70 years of age is the cutoff limit for Indian seafarers, irrespective of the flag. But still, if a company feels he needs to send a seafarer beyond 70 years, then again you must take a permission from the Mercantile Marine Department. The last year data, we took only 39 seafarers above 70 was sailing on ships. 39. Out of that, majority were on Indian ships. So we presume that normally foreign companies, very rarely they employ a seafarer, but still we kept the option open. If somebody is fit, if you want to send the person on board, you please send him to MMD. Take a permission. That is for 70 years. This is with respect to Indian companies and foreign companies. Third criteria is for the doctors. Any DGS approved medical examiners, does the medical examination of seafarer above 65 must send the report to MMD, irrespective of the fact whether it is going to Indian ship or a foreign ship. For a medical examiner, the criteria is the age. If you do any medical test of seafarer above 65, you have to report to the Marine Marine Department. But that is presently is a manual, you send it by email or whatever means. But very soon when the online system starts, so that manual intervention will stop. You will be anyway uploading all the reports. Then that we will take out that requirement. In the interim, if you do the medical examination of seafarers above 65, the immediately report must be sent to MMD. Copy of the report should be sent to MMD. At least we can keep a watch on that. These are only 3 requirements. I hope, sir, this is very clear. I'm sorry that if, sir, I'm sorry if the circular was not very clear, but we have put it up on website for 2 weeks for comments. Many comments were received, then finalized the circular, but still I think maybe our language was not so clear. But this is the only thing. As far as all ships, foreign flag ships, 70 years is the cut-off age. Thank you very much. Yes, sir. Yeah, please.
Doctor is sending an email to a particular point, whatever you have prescribed, for any seafarer who is above 65 years of age. Do they have to wait for acknowledgement from MMD or DG, or they can just...
So I said that there are requirements for companies are different. Above 65, Indian ships, Indian flag ships, permission has to be obtained from the MMD. For ships without lifeboats. Okay, sir, that is a company responsibility. Foreign flag ship or any ships above 70, again permission has to be any ship, whether Indian or foreign lifeboat, any ship above 70, permission has to be obtained from MMD. This is very clear as far as companies are concerned. As far as the doctors are concerned, they are not bothered about the ships. They are bothered about the age of the seafarer. If they do medical examination of seafarer above 65, we need to collect the data. Which doctor is giving medical? We have already seen the trend. We are already collecting data from e-governance. The specific doctor, the thousands of certificates are being issued. So we are collecting the data, So as for the doctor, they must send a report to MMD that yes, I have conducted a medical exam ex-seafarer and this report is attached. He will hand over the original report to seafarer. And there is no permission. They did not seek our permission for conducting the test. I hope I am clear.
Because this query, Captain Azad, this query came from one of the doctors who had carried out a medical examination for a captain who is 65 years, above 65 years of age, and the doctor had sent the report to local MMD, but there was no reply coming from MMD. That's why this query.
Don't take. If a reply is not there, so everything is okay.
Okay.
So, okay, sir.
So this is on behalf of all the medical practitioners.
So sir, let me tell you, sir. So administration cannot regulate each and every activity. It is done randomly. We may be receiving hundreds of reports, but we may check only 1 or 2. But at least we want a data that which doctor is, like why the particular doctor is getting all the aged seafarer. So that is what we wanted to get the detail. But when e-governance comes, we will get a very detailed, detailed information from the e-governance portal. So that will not, but even another thing regarding this 2 doctors, sir. So there are 600 and I wanted to clarify, we don't approve the clinic. We only approve a medical examiner only. Okay, sir. Just let us be very clear on that. DG Shipping does not approve any clinic. In our approval letter, it only the name of the medical examiner is mentioned and address is mentioned. Okay. For approval of examiner, there are some criteria, some space and all. If somebody doesn't have any testing facility, he can have a tie-up with any other laboratory for testing. So, regarding the 2, why we made it into 2? Because there are several complaints came that some from some location medical doctor certificates were being issued. But when we checked, they said, no, this doctor has already gone. he's not there now. They keep on changing the doctor. Like let us say some specific, like maybe major clinic, they are employing a lot of doctors. What we thought, why can't they open a clinic somewhere else? Why they will have to put it in only one place? That was what our, consideration. That why in one particular place 3-4 doctor has to be there. They have to spread out. We have 600 doctors approved all across India. The companies must go to some other doctors. Why they will have to go to a particular person only? So there is no restriction for a doctor to, let us say if some doctor is going to a clinic in CST area, we can give approval if wherever near his residence he can open some clinic. What is the basic minimum requirement for a clinic? Approval will be given because we are giving approval to the doctor only. Why the doctor has to be go to that particular clinic? That's what we wanted to break that mandatory thing that no, you have to come to my clinic only, then only you will be given approval. So that, but anyway, we are open to review of that whatever conditions are. We are open to review, and that will be reviewed by the during the deliberation, and then we can come out with some practical solution. Okay,
sir, I must say, real estate in Mumbai is expensive and metros. Not easy to open up additional clinics, and if I'm in a very densely strategically located place like Andheri Kurla Road, and there are major big brands, and I have a big space, I can have larger footfalls with more doctors managing that.
We are open to that, sir. We will discuss and we will. But what we wanted was the seafarers should not come to Mumbai. That was what our. They should be doing medical tests wherever they are. So that's our ultimate aim. Thank you very much, sir.
Thank you, sir.
Sir, I think that I fully agree that is a. There are some companies have some issues, but most of the companies, see what happened by this circular, we have removed the ambiguity that earlier there were a misconception, the rating has to retire at 60. And officer can go. But now by this circular, it is irrespective of whether ratings or officer, this is a rule applicable. Ratings also can go up to 65, ratings also can work. Otherwise, ratings were forced to retire at 60, but there is no such rule. So we have clarified by this also. This is applicable for all the seafarers, not only officers. They can work up to 65 if they are medically fit. Employment is up to the company. So I think if somebody is good, they will take it. I am seeing so many persons and all. They are working, above 60, 63 and all.
Yes, sir. You are encouraging the 65 above, engaging on board the ship 65. What some of the company neglecting 55 below? There is any guideline from your side?
So from our side, there is no restriction. It is up to the companies.
So we are seeking the food of the stomach. That's it. We see the.
I think you know very well. So that's the employer has to decide. But obviously, the employer should not be biased because of the age and all. So that I think we are receiving a lot of complaints. I must say that. Like recently, we received one complaint. I did some cataract surgery. Why the company is not taking? A lot of complaints are coming to from the seafarer. But I was telling our CMS team, we will have a feedback section in our portal. If somebody is rejected for whatever reason, seafarer will be able to upload the details why his medical test was rejected. So we will have a feedback also, and seafarer can take a photograph of the laboratory and upload there. There is even samples are not collected properly. Like you see some filthy condition in some of the laboratories. So we will have all kind of options. Every day it will be monitored. Some seafarer can just take a photograph in mobile and upload it in the system. This is how the DGS approved laboratory looks like. Okay, so I think we have to come to some standard. There are many of you are doing very well, but there are large number are still below the mark. So our target is to bring them up to the standards. And the last point I want to request the companies that please share your studies, whatever you have, about the failure. Don't try to keep it secret. Please share it with the administration, and we will discuss. It is not to take action against the doctors, sir. Let me assure you that we are not here. When we are analyzing the data, like some death has happened, now we immediately Captain Nitin will be asking you to send you the medical report. We are not trying to find fault and take action against you. That is never an intention. So we want to improve the standard. So we will give some kind of guidelines as based on whatever experience faced. Please share the information. And so some companies are doing audit of the medical doctors. Please share the report. So finally our ultimate aim is to improve the quality of medical examination of seafarers, so that there should not be any mishaps, any death or any coming back due to the medical condition. That is the ultimate aim, not to take action against the doctors. So with this, I want to conclude my remarks. Thank you.
Thank you, Captain Azad, for patiently answering all our queries. And as we come to the end of this panel discussion, I now request Captain Dr. Rajesh Tandon to please join us on stage to felicitate our panelist and the moderator. So our esteemed panelist here, Dr. Corinne Adnani. Thank you, ma'am, for being here with us. Dr. Dushchand Barfiwala. Captain Arun Mehta. Captain Deepak Korea. Captain Vikram Singh Manhas. And Captain Deepak Gupta. I request all of you for a group picture, please.